So we'll change a bit of data model. We speak about conception. I have no conflict of interest. I just would like to say that we are a research platform from Bordeaux University, and so we love collaboration. So we have been working with the CDM, with Peter, with Odyssey, but in the scope of other collaboration, we also use different CDM, and I would like to take this opportunity to present you a different one. So we are speaking about Conception, which is an EMI project which has been funded in 2019. The project counts around 88 public and private partners under the coordination of the Utrecht Medical Center in the Netherlands again. Conception basically aims to establish a trust ecosystem that can efficiently, systematically, and in an ethical manner address questions around information, safety and effectiveness around the use of medication in pregnancy and breastfeeding. When we are speaking about generating evidence, we refer to claims, to healthcare databases, to electronic health record, registry, and so on. And in the scope of this project, we had to create a federated network of 20 European data access providers to make them able to perform distributed analysis in a robust and transparent manner. So we had to choose a common data model, and that was a very challenging choice to make. As Emmanuel Bacri said this morning, there are several problematics around the choice of a CDM. The first one is interoperability, how to make very heterogeneous databases interoperable, and how to do that in a transparent manner and in compliance with data protection regulation. We also have a specific prerequisite because we are in the Conception project, which was to preserve the granularity resulting from European data. And the one, maybe the most important, was to comply with timelines and budgets allocated for this study. So what we first thought was indeed to the CDM. I won't say much about that because I think that you already have had very good presentation on this topic. I just would like to remember some very specific features, and that's very excellent, which are in OMOP you need structural harmonization, where to put your different variable and under which label, and you also have to go through a semantic harmonization. That means that you need to translate all your local vocabularies, if it's not already done, to the OMOP standardized one. And after that, you are able to use all the toolbox developed by the community and to generate evidence. The main issue, if I can say it is an issue, is that you need time to do that. So this high level of standardization imply complex and costly procedures in terms of time, but also skills. As you have seen earlier today, you need the local database specialist, you need ontology specialists, mean that you have to find physicians, pharmacists, biologists, experts in the different terminology. You obviously also need data manager, data scientist, analyst, and so on. And so in the scope of Conception, with more than 21 data sources from France, Spain, UK, Germany, Netherlands, I'm sure I'm forgetting many of them, that would have represent a huge amount of work and a huge amount of money that would have jeopardized the execution of the full project. So we had to find an alternative. And this alternative comes with a slightly different philosophy. What we decided in the frame of Conception is to only require a structural harmonization, meaning that each data source, each partner was able to use their own ontologies. And then you are able again to use all the developed tools of the Conception framework. So is what you did. Based on this philosophy, we conducted a content analysis of the 21 participating data sources via structured interview with each one of the data access provider that we grouped in what we called database family. It's very small on the screen, but that allowed to identify hospital administrative claims, inpatient registry, birth registry, and so on. And from these different families, we derived the table of the Conception common data model There is nothing very new. I mean, the structure that we'll see just after is more or less, I mean, is totally patient-centered, like the OMAP one. To go briefly about the table of this CDM, you have 4 categories of table. The first one are the green one, which we called routine healthcare data. So you have medicine and vaccine tables. Then you have events tables that contains all the condition and the diagnostic. You also have procedures with the medical and paramedical procedures. You have medical observation that can be free text, discharge, also measurements, for example, blood pressure and so on. All these tables are linked to the visit occurrence table that captures the encounters with the healthcare system. That can be pharmacist visits, that can be hospital stays, and so on. All the healthcare data are also linked, obviously, to the person tables that contains all the demographics around the person. And this person table is linked with the observation period table that captures the period of time during when patients are present in the database, and the person relationship tables that allow to link patient between them, for example, mother and child. Another category of tables are the dark blue one that we called surveillance data. So you have survey observation that allow to capture data around, there are mainly registries, abnormalities, registries, all these kind of elements, but also that can be ad hoc survey that have been conducted with specific questionnaires. We also have the EuroCat tables, as conception is about pregnancy. We also use EuroCat.
Which has just disappeared.
But that will come back soon, I'm quite sure. So the EuroCat table, in fact, is derived for a previous study around abnormalities in children. It's a pre-standardized table. The last category of tables are the metadata that's basically allowed to describe the data we are storing inside of the CDM and to describe in more details medicine and vaccine, for example. Well, now we have spoken about the general concept of the conception CDM. I would like to highlight some example. So in these slides, we have extracts from two data, which are Italian and French. On the left side of this table, it's the events table, so the one that captures basically a diagnosis. You have the person ID with the corresponding start date and end date. On the right side, you have the visit occurrence ID that allow the linkage with the visit occurrence table. Something very specific of the conception CDM are these two variables in the middle, which are code event and event vocabulary. In fact, that are the variable that allow the use of scripts calling for multiple vocabularies. So as you can see on the screen, for the Italian data, you have ICD-9 CM codes, and for the French one, you have ICD-10. Something also interesting, it's the meaning of event variable that you have here that captures additional information that may be of interest for analysis. Basically, on the example on the screen, you can see that in Italy, you have data coming from primary care settings and hospital settings. And in France, in this example, you only have data from the hospital settings. Now we have spoke about the data, a few words about distributed analysis. I know that it's a concept that we always hear about, but sometimes it can be a bit fuzzy. So to make it simple, when you deal with several data partners, you have several data sources that have been converted to one CDM. In our case, it's the conception CDM. You have one core protocol describing the research question and the aims and the means you have to implement to address them. And so from this protocol, you draft a common analytical script that will be executed at the local level in the different databases. In our case, this analytical script encompasses what we called a concept set, which is basically a list of DAP-specific codes that help to characterize outcome of interest for the study. You have an example of what can be a concept set. So in this case, it's the ALI concept set, the acute liver injury. And what you can see is that you have the list of the different ontology that can be used in the script with the corresponding codes. The last stage of the distributed analysis is to pool the aggregated results to generate a core of evidence to address the research question. A few words about the pro and the cons. So the conception CDM, I mean, the level of standardization we achieved in this CDM allow us to use common analytical script, even if we need to slightly adapt them to the data source that are participating to the study. There is no a priori semantic harmonization that allow a fast, flexible, and transparent deployment, and that help to preserve the data granularity. You may have already heard that to translate it's to betray. I think that this statement sometimes may also be applicable to real-world evidence, because it's always very complex to characterize complex outcome when you are dealing with translated codes, because sometimes same standard code may have slightly different meaning in different databases. When you translate, you always interpret the terms that you are reading and translating. So some perspective. So far, we achieved to convert 25 European data sources to the conception CDM. We converted the few 31 in less than 10 months. The conception CDM is used by several research networks and several NCEP Center of Excellence. We have, for example, the Vaccine Monitoring Collaboration for Europe, VAC4U, which is an international association that aims to strengthen the real-world evidence, the real-world assessment of vaccine in Europe. We also have the Sigma Consortium, which in fact is a consortium formed by several NCEP Center of Excellence that aim to facilitate expertise sharing and data access across Europe. We also have the Utrecht University and its partner that collaborates through the conception CDM to address the question that the EMA asked through the European Pharmacoepidemiology and Pharmacovigilance Framework Contract. And all this synergy between methodological expertise and conception tools facilitate the deployment of distributed analysis. An additional collateral effect, if I can put it this way, of this more easy collaboration is a more easy access to the database themselves. All the consortium I introduced earlier allow for most of them to access different databases through centralized requests. So you can address your question to one consortium and have a feasibility assessment of what can be done in the several databases. As you can see on the table on the bottom of the screen, that is a draft from the Sigma website, there are a very wide brand, a very wide landscape of type of database and also a geographical area. What have been achieved through conception during the last months? So the conception CDM have been used in the IMI conception project, indeed, specifically in the demonstration project, but it also served as a very strong catalyst in the fight against the COVID-19 pandemic that is also affecting the camera and the screen, I guess.
It's going to be bad.
It's going to be bad.
Sorry.
That's great. So we conduct the access study that have been commissioned by the EMA to calculate the rate of 37 adverse events of special interest. 77 adverse events of special interest before COVID-19 in 10 different countries. That also it has also been used as support in the frame of the Consign project, which try to focus on COVID-19 and pregnancy. Conception CDM has also been used in ROC19 and ROC20 that have been commissioned by the EMA again to monitor the real world, the safety of the safety of COVID-19 vaccine. We use it also for two projects for two post-authorization safety studies on retinoid and valproate that were risk minimization study. And the conception CDM have also been used and is being used in the frame of 4 different PACEs, so post-authorization safety study, for the current COVID-19 vaccine. So the one from AstraZeneca, the one from Moderna, Pfizer-BioNTech, and Janssen. So that's the scope that have already been achieved through this CDM, and I hope that that gives you some idea for perhaps future collaboration using this standard. Thank you very much.
Thank you very much. Thank you very much, Nicolas, for this very nice presentation. I think we'll have the time for maybe one question. We're running a bit late, but we have already one from the chat, but we can take also one from the audience if there's one. I'll start here, and if one comes up, we will go on. You mentioned that converting to OMOP CDM is costly in terms of skills and time, but how is creating a custom-made CDM less costly since you start everything from scratch? What is your opinion on this?
Well, that's a very nice question, because there is two aspects when you are using a CDM: is the creation of the CDM itself and the implementation of the CDM in different databases. In the conception CDM, we have in the conception project initially, because that's the source of everything, we had money to design a CDM, but the more costly it's to implement it in the different data sources. And I think that all the people that go through the OMOP implementation have kind of an idea of what I'm talking about. So the idea was to minimize the burden of the implementation of the CDM for the different partners. So it was very more economic to use this CDM, which is slightly derived from the OMOP one. I mean, we didn't start from scratch, but saving this time of translating the vocabulary, we save a lot of time for our partners.
Thank you. Do we have another questions here? Okay, yes? Giselle, maybe? Yes.
The data model does not seem so far from the OMOP common data model. Can you imagine any possible merge in the near future?
Well, yeah, to be honest, so even in the OMOP common data model, you could have chosen just to only use the source code concept. So I missed the point a little bit why that needs to be another data model. And also the tables that are added, I think, can also be, the data that's in those tables can also be in the other tables already. So I missed a little bit why there was such a need for that. But I mean, it's working, so I think it's fine for the project. But I missed that a little bit, to be honest.
So maybe
I can speak about that. So as I said, we worked with OMOP, we worked with conception, so we have an experience of the different aspects. I mean, it's complex because what I'm gonna say, it's the strength of OMOP, but also from my point of view, weakness is that OMOP come with a lot of infrastructures. There is not only OMOP, there is all the stuff around and all the very standardized tools that are provided, which again is a strength when you work with many, many different partners, and that sometimes are very easy to carry when you are working with a few one. So doing it this way was trying to design maybe something more simple, more flexible, because OMOP is nice, but is very strict and is needed to work according to this model. But that may be overworked for some people that want to adhere to the model quickly. And as I said, most of the study that I show have been implemented to address the question of the pandemic in Europe, where very few databases were converted to the OMOP CDM. So there were needs to tools to address this question quickly. And well, conception was the answer.